slides. That, okay. My slide will soon come off. Trying to see. Is it so? Oh no, but it was my website. Sorry, this is not the one. Shit, go. Hello, can you hear my slides? Can you see my slide, please?
Not yet.
All right. So let me share again. Okay. Let me take you to.
Yet.
Okay.
Yes, you just have to
So
put it in
it's
presentation mode. Your slide
yeah,
is
it's
not
coming.
visible now yet.
Yes, it will come up now. It
All right.
should come up.
Thank you.
Okay. Is it visible now?
Please let's remember to mute our mics, please.
Okay.
Great, great.
Yeah. So it's coming slowly. Maybe the network is. I'm trying to take it to the first one. All right. Good afternoon, senior colleagues. My name is Dr. Hassan Ibrahim, the Zamfara State Public Health Emergency Operations Center, IPC Pilalit. And it is my great honor to be with you here for the first time to make the presentation based on the activities and the struggle we are doing on trying to improve the IPC activities across our levels. As it appears on the slides, my affiliations are there. Well, I want to start with an introduction so that I can bring all of the participants up to speed on what we are and where we are with regard to the IPC activities in Zamfara State and the success we have recorded, in addition to some of the challenges that are everywhere. You cannot preclude the fact that challenges may occur, and that's why you should be able to know how to address those challenges and forge ahead. Well, in recent times, Zamfara State have experienced multiple outbreaks, which cut across all the 14 LGS, despite the efforts put in place by the government partners in trying to contain these outbreaks. It is also important to note that more than 3 years now, the state has been battling with multiple outbreaks on one season or the other, which include cholera, diphtheria, mpox, measles, polio ulcers, CSM, baby metal poisoning, polio, and most recently, last fever case in Tlata Mapura, which was already contained. Among these highly infectious diseases, cholera outbreak of the year 2025 was a very good study for us to learn, in which it was more widely distributed, with about 15,176,046 suspected cases, with 67 of them lab compound, and with the total death of 199 as at December 2025, the equivalent with 44 of the year. It is against this background that we all understand that infection prevention and control measures remain an essential component of supporting effort in containing outbreak at all levels, not only in Zampresta, but in our own case study, we also understand that infection prevention and control is an indefatigable component of containment of any outbreak. Also, all the outbreak responses conducted, infection prevention and control measures were not satisfied enough to effectively address the issues regarding breaking chain of transmission within the facilities and also at the community transmissions. Then also the usual perception was PPEs are only important component of IPC that needs to be captured, especially when developing Instant Action Plan, IAP, in which the expected amount of money to be consumed or given to that outbreak, to be budgeted for the outbreak, as review depending on the time lag of that outbreak. This is also another thing that we are always trying to change the narratives with regard to that IAP, given an IPC a standalone consideration. It appears that every healthcare worker, every healthcare level, primary, secondary, and tertiary, has a huge gap on IPC, and some lack the understanding that IPC is a standalone skills and therefore need to be learned as such. Partners supporting the state on various outbreak have no specific plan on IPC, hence they give it only a casual look. And this form major reasons why we have most of this outbreak lingers for a long time. Then what are our bottlenecks? Some of the identified bottlenecks are majority of the healthcare workers lack the IPC skills, especially at primary healthcare level, where multiple outbreaks emanate, but handling with poor or no IPC's application skills and this transmission. It is therefore there is also a poor or inadequate IPC material supply to facilities, especially during the outbreak period, due to full attention given to IPC when budgeting or supporting the outbreak response and routine healthcare facilities services. There are many healthcare institutions operating and graduating large number of TUs, J2s, community health, medical records, epidemiology and disease control, optometry, lab scientists, and nutrition. However, none of these institutions provide attention to an IPC training or believe it to be a standalone skills. That's where we have also our emphasis on making all the effort, and we have a success story to tell in this presentation. Most of these students form more than 90% manpower of primary healthcare, and they are the starting point for early case management in the wave of an outbreak, in addition to the routine healthcare services delivery. Then what are our implementation strategies in trying to address most of these gaps in collaboration with the Department of the Public Health, the Ministry of Health in general, the partners supporting the state, and also the management and staff of the Zampresta Public Health Emergency Operations Center? The strategies are as follows. We leverage on the gathering or training of healthcare workers to include IPC discussion for the participants, especially those who live in an inaccessible location due to insecurity and banditry activities. While we are having a good story to tell based on this, we also at our level as IPC practitioners and experts in the state, anytime there is any healthcare workers gathering, be it a training on different aspects, be it they are called for a meeting, be it they are coming for any gathering called by the state or local government or the hospital services management board, we leverage on that opportunity to deliver a very robust and very comprehensive lectures on IPC, so that our healthcare personnel can go down to their individual facilities and cascade the training to their staff. By so doing, we are expanding the horizon of the IPC practice and its applications in our state, so that it can help us to address most of the challenges we have mentioned so far. We also are advocating for all partners supporting the state on health intervention, especially outbreak response and healthcare facilities based intervention, to include IPC activities. Notably, among the success we have recorded on this was when we have the issue of the heavy metal poisoning at the infectious disease hospital. We leverage on that activities across all the partners supporting the unprecedented on this regard to train all the staff there based on IPC skills to practicalize IPC activities in this, among the staff of those hospitals, to also leverage on that activity to train the entire clinicians in the state based on IPC so that we can be able to address issues squarely and in accordance with the IPC standard. Then we are also advocating, these are some of the activities that are still ongoing. We are advocating for healthcare institutions operating within the state to accept our recommendation for making IPC to be a standalone course and should be taught in all departments. We are very happy to announce to our participants and our moderators that we were able to make this a reality. Presently, I am leading a team that is designing the IPC as a course in some of the healthcare institutions in the state and also developed modalities on how that IPC course can be trained. I also want to be happy to inform the House that I have developed the modules with two different segments. One is theoretical segment and the other one is for practical segment. And we have piloted a department where we have students on epidemiology and disease control, community health, and also medical records. We are piloting this department on this IPC because the first of its kind in the entire history of all the healthcare institutions operating within the President. We have reached an advanced level of finishing these modules. And personally, I have started going into classroom teaching the IPC as a course. We have given it a title, IPC, Infection Prevention and Control Skills as a course. Then we have given it a code. We have given it also to be a 2-credit unit course. And we are also in discussion with other healthcare institutions inviting us as IPC to come and also deliver such kind of initiatives in their school. This is a very important and very robust development we are having as far as the IPC in Zampresta is concerned. Then due to nature of state with the pre-com multiple outbreaks, including Lassa fever, discussion is ongoing with the NCDC official on how a special attention and support will be given to IPC activities at all levels. Just yesterday, we were on the field together with some of the NCDC personnel, as we are going to see in our gallery, and we have been discussing on how Zampresta will have a special consideration and intervention as far as the IPC is concerned. Because over the years, our experience has shown that IPC has gone beyond only within the healthcare facilities. You will see on our gallery how we have justified the fact that IPC is beyond the healthcare facility. We need to extend the knowledge of the IPC at the community so that we can be able to help those community members to break the chain of transmission at early stage of any outbreak or an infectious disease going on in that community. Then the process of adopting, gazetting the IPC document policy provided to all states by the NCDC is still ongoing. At this point, I want to thank the doggedness and the effort of our Director of Public Health, Dr. Yusuf Abubakar Haske, who has been the front liner on trying to see how IPC document will be domesticated, gazetted, and also being as a policy in Zampresta that all those documents highlighted by the NCDC is going to be applied squarely in Zampresta. We are also thanking him for giving us all the support of the activities we are doing as far as the IPC is concerned, and even denominating most of the experts on IPC. He nominated them to go and attend that training on CCAPS sponsored by NCDC and Global Fund. This is our gallery. If you look at our gallery, we have divided our activities into two segment parts. We have the engagement and we have the fieldwork. If you look at plate A, this is myself, state epidemiologist, and other representatives from the Public Health Emergency Operations Center on air trying to explain to people how they can be able to adopt some of the IPC measures and trying to break the chance of transmission of most of the infectious diseases going on in the community, in addition to the effort put in place by the state ministry and developmental partners supporting them prested on that regard. If you look at Plate B also, is being given electors an opportunity I have gotten to give electors to the healthcare workers from the Talatal Mapara local government. All the healthcare workers working in that LGS that has 11 wards, I had the opportunity of gathering them together with the MSF and give them the IPC training for good 3 days. While if you look at Plate C, is also another opportunity we had here in Gusau with healthcare workers, particularly CHUs and JCHUs, giving them an IPC training so that they can be able to cascade it down and also apply it in their day-to-day routine activities at their respective healthcare facilities. Plate D is also showing a robust engagement with all the PMOs within the president, that is those who are heading secondary healthcare facilities. We are giving them tips and also bringing them up to speed on how they should be able to have IPC committees in their respective health facilities. That is our engagement on the uppermost row. Then if you look at the downward row, these are some of the NCDC staff. If you look at Plate E, we are at one of the cholera hotspots in Zurmi local government just yesterday. Look at Plate F, look at the water these people are drinking, look at how they are using this water, and that is their major source of water. Don't forget the fact that it is just less than 1 to 2 months we have started experiencing the rainfall down in our community in this part of the country. Yet, this community, they have started to grow its hand well dug and beginning to get water they are using. This is a very highly contaminated water, but our advocacy and our on-the-spot assessment visit is just changing the narrative, because we have explained to them, we leverage on this opportunity to teach them on how they can be able to treat this water, or how they should be able to restrict themselves to using the only one hand tap borehole constructed to them by the MSF, so that they should be able to stop using this kind of water that is likely to be contaminated or highly contaminated. Then, if you look at Plate D, this is also another field work where I personally, in collaboration with the WHO staff, demonstrating on how PPEs should be donning and doffing, so that our staff working on the field can be able to use them effectively. Because over time, what we noticed while trying to put this PPEs is either a staff will contaminate himself, or at the end of the day, he's just putting them up wrongly, and at the end of the day, the end will be defeated. So that is why anytime there is any outing with any of the developmental partners, we go together as IPC experts to demonstrate to the people, to the field workers there, this is how you should be able to use it. The last plate is a clear demonstration on how we have collected the sample from the anthrax suspected animals or anthrax suspected carcass in Oranamo, the LGA, with full PPEs on, so that field workers, health workers, and every member supporting any health activities in that LGA should be able to know and understand how to use this PPE, so that we can be able to have effective infection prevention and control. So this is what we have been doing. So based on this, IPC is beyond health facilities. As far as the unprecedented scenario and understanding is concerned, IPC is no longer a facility-based affairs. It's a community and facility-based affairs. Reason being that any outbreak we do expect or we are about to have, it starts from the community. And whenever you see a case being reported to a community, we as the epidemiologists will look at it as a tip of an iceberg. Many of it, thousands of it are there going on in the community without reporting to facility. So that is the reason why in our own template of operation here in Zamfara State, in collaboration with the support from the Zamfara State Ministry of Health, developmental partners, we are looking IPC beyond health facility. IPC is across facilities and community. Thank you very much. At this point, I want to acknowledge the contribution of the Zamfara State Ministry of Health CCAPS, MPENTIP Police, Publishers Emergency Operation Center Management and Staff, the NCDC, the NSIC who gave me the opportunity to make this presentation, my partners in IPC activities, and my colleagues in CCAPS. And also, we want to appreciate the support of eHealth, where we are having an uninterrupted signal when we are doing anything remotely to our people at the community. We also want to appreciate the giant stride of the UNICEF, who are always on the field together with us in trying to address issues. So IPC has become the affairs of every development partners in Zamfara State. Thank you very much, and thanks for your attention.
Wow, very commendable. Very, very commendable. Please let's appreciate the efforts of Dr. Ibrahim Hassan and his team in championing IPC in his state, not just in his facility. Please, can we appreciate him with our best emoji? Dr. Hassan, well done. Well done to you and your team. It's really beautiful to see all of the great efforts, not just limited to your facility. Okay,
Thank you
somebody
very
is
much.
saying, well done, great job, great job. Do we have any questions based on some of this presentation, comments? Are there things that are very striking to you that you might want to learn from him? This is experience sharing. This is our spotlight section where we get to share experiences from our various facilities. So I don't know, do we have people who want to ask Dr. Hassan questions based on his presentation or make a comment or contribution?
Amaka, maybe comments.
Comments, yes, comments, please.
Comments, questions, reactions. Maybe while they're waiting, I would just say, Dr. Ibrahim, that is very, very commendable. I'm so proud of you. And, and I hope we all be passionate about infection prevention and control, that we shouldn't just keep the knowledge, with us. Because if you just keep it with you, it's really nothing. And I like the fact that you're working with partners, because there's no way one person can solve the problem. It's our problem. And I like the fact that you're even taking it beyond the health facility. The other day, somebody was talking about the community members, because ideally, we'll talk about patient safety, health worker safety, but even the community member safety. We are talking about, say, water that is highly polluted, but that we need policy. You need it from the local government to the state government to provide clean water. And I'm sure UNICEF and all the other partners will do something about it. That's very commendable, and I just want to give you, I doff my cap. Thank you, congratulations. But remember, result of good work is more work. And I'm sure you are equal to the task.
Yes, ma. Thank you very much, ma. I'm very grateful.
Okay, so there's a comment here. Someone said, this is great. I've also worked at Zamfara through one of the villages called Paru. I've gone through Maradun LG, and with this presentation, I'm happy something good is coming up this way. Though it's been a long time, I've been back there. I look forward to witnessing this myself. Thank you, Doc. Well done, Dr. Ibrahim. Everyone is saying well done. Well done. Do we have more comments? Okay.
Maybe if you don't have any comments, has anybody picked anything positive that you've learned from Dr. Ibrahim? Because we are supposed to learn from each other. Dr. Ibrahim Hassan has done something in Zamfara State. Do you have a similar experience to share, or you just picked up something that you think you want to go and try? Let's rub our minds together. Don't just keep quiet. Thank you. Hands up. Let's talk. We're not just here to listen, because infection prevention and control is not just talk, it's work. You walk your talk. Oh, please talk. Amaka, look out for hands.
Contributions, comments.
We haven't learned anything.
Yes, there's a hand here. There's a hand from Dr. Sani. Please, you have the floor before I call on it.
Thank you.
Yes, please go ahead.
Thank you.
Thank you very much. My name is Sani Said from NMSL Abuja. So I would like to start by appreciating the presenter, Dr. Hassan, for a job well done, a wonderful presentation. And I'm from Kaduna State, so I know how important IPC in the northern part of Nigeria is because of the nature of our society, you know, the exposure, the how will I put it, level of knowledge of IPC in the north and the northwest. So this is a commendable presentation and a wonderful job, and we really want to see more of this research is done in order to prevent outbreak of diseases. And I would also like to ask Dr. Hassan what plan or what are they doing, putting in place to make sure that there is a proactive measure, you know, in preventing the outbreak of diseases, you know, in Zamfara State, and the research he has done, whether the relevant authorities, you know, are aware and they are working on, you know, using it to prevent outbreak of infections. Thank you very much, Dr. Hassan.
Okay, thank you very much. Am I free to respond, Mark?
Yes.
All right, thank you very much for these questions. Well, the proactive measures we have put in place are so many. One of the proactive measures I have already mentioned, by the time we notice IPC is beyond facility, then we start thinking on how do we change the narratives. Then we look at it. About 90% or more of our primary healthcare workers are coming from various healthcare institutions operating within the state. But when we notice there wasn't any cost with regard to IPC that is being putting these people through, then we advocated for this course to be part of their courses they are doing, and we were able to achieve that. And we didn't stop at only this. We went ahead to also design the course ourselves so that we can put practicals and theoretical aspect. And as I have said it earlier, I am the one leading this, and I am the one designing the course together with the other IPC expert. And we have started taking these children, students in classes. That is one of the proactive measures, because if we wait until when they become healthcare workers, then we may not have the opportunity to grab them in one particular place and train them until when we have an opportunity to do so. But by the time we get to school where they are trained and give them this training as a course, then we have solved the problem of them going to communities. All for them is to cascade it down. That is the regarding to proactive measures. Then the second proactive measure was the domestication of the IPC policy document, which I have already mentioned through the support of the Director of Public Health, Dr. Yusuf Abubakar Haske. We are working assiduously to see how we are going to domesticate it, gazette it, and make it a policy, because it was given to all the state by NCDC, and we are seriously working on that. And again, we need an IPC committee across facilities. If you see my plate D, there was a congregation of the PMOs, who are the managers of the secondary healthcare facilities in the state, and we are persuading them and advocating for them to have IPC's committees in their various facilities. It's part of the proactive measures we are doing on this regard. Then with regard to research is also an affair that is always ongoing. But what I can tell you, the one I have done, I wanted to understand the baseline of the IPC compliance across our facilities. That is why I have designed and initiated the research myself, and I have found my result. And I'm still talking, discussing with the various health facilities based on the findings we have found from their own staff, healthcare staff, and we are trying to design modalities on how we are going to improve the situation we have found. So at this point, this is the thing I can be able to say with regard to proactive measures and research we have been doing as far as the unprecedented scenario is concerned. Thank you very much.
Thank you. Amaka, can I say something?
But please, before you go ahead, please,
yeah,
I would like
Dr. Ibrahim, you've done very well.
Okay.
But one thing I was waiting to hear is, do you have an IPC committee at the state level and at the health facility level or the local government level? That is question one. Then question two, if you do, is there a plan to have a supportive supervision? Because when you train adults, adult needs to be you need to enhance their learning. You need to do supportive supervision because they tend to forget, or it's not just the knowledge. They may have the knowledge, but of course they need the supplies to ensure that they do what they're supposed to do. I like the idea that you develop a curriculum, bringing down to their level, because we shouldn't say everybody should be at the level of CCAPs. We should come down to their level, and then different cadres with different training. After the training, do we have a supportive supervision training? And do you have trainings for laundry workers, cleaners? Do you have them in? I don't think I got that, or maybe I missed it. Over and out.
All right, Ma. Thank you very much for these very important questions. Well, as I have said earlier, IPC is also activities that in most of the facilities or even the clinicians things is something that everybody knows, every healthcare workers know. They did not recognize it as a standalone skills that needs to be learned alone. So that is why at this level now we are advocating. By the time we have these committees in place, definitely assessment, compliance, supervision will come in so that we can be able to maintain and sustain the effort we have put in place. But at this level now, we are trying to have the committees, that is the working we are doing together with other IPC experts in the state, because we know having a committee is key. Supervision is also a key in as much as we want to sustain the activities and training we have been given to healthcare workers. That is ongoing, and I assure you, Ma, the next presentation, you will hear the outcome of what we have done on this regard.
I'm so glad to hear that. Thank you.
Thank you, Ma.
Thank you.
All right.
Over to you, Amaka.
All right. Thank you, Ma. Thank you, Dr. Ibrahim. So there's a hand up from Godia. Dr. Godia, please, you have the floor. Go ahead with your question or contribution.
Good afternoon.
Good afternoon.
Good afternoon. Yeah, I want to first of all commend the doctor for a very good presentation. That was actually marvelous, and I'm so happy. The point that actually interests me in this conversation is the fact that they went down as far as capturing the community health into this idea, because the community health has the largest manpower when it comes to the health sector in Nigeria. So as such, is one of the things that we can actually do to help us reduce this issue, to train a lot. In fact, it's being part of the curriculum covers largest part of the issue. So I'm so happy to hear this. The only thing I would have loved to hear more on this is that I'm one of their primary healthcare educators. So I don't know how other states, how the federal level can actually replicate such action to be applicable to all the places, seeing that he and others are part of people that are actually into the classroom doing this job. They are not enough. So I don't know if there are plans on ground to see that the primary healthcare educators are actually trained on this issue, so that this training will be done appropriately to the students. Thank you very much. I'm grateful, ma.
Thank you so much. Thank you for that contribution. Okay, so let's give the floor to Abba. Dr. Abba, you have the floor now. Go ahead.
Good afternoon, ladies and gentlemen. I want to commend the organizers and the presenter for a very good presentation. This pictorial presentation is what I was about to talk. There was a picture indicating anthrax. Sorry, let me properly introduce myself. I'm a veterinarian, and looking at the interaction between humans and animals, and a source of diseases that cross between the two species, I believe there is need to nip it at the primary level. So in his picture, I saw an anthrax bullet, but he played it very low, and being a zoonotic problem, and I know it's already existing. Uh, Vaccination have gone in the animal sector, and I think there were few human cases, and I think educating the farmers vis-a-vis the animal keepers in terms of preventing and controlling diseases is very, very important. What is IPC doing about that? Thank you very much.
Dr. Ibrahim, you can go ahead to respond.
Thank you very much for these questions. Well, the plate you saw where we were taking a sample of anthrax, it was an outbreak that happens last year. And because we have a robust surveillance system in which both human sectors and animal sectors, environmental sectors are combined together as rapid response squad or rapid response team across all the LGs. So we were able to trace and also get this case at its early stage. So on getting the report of this outbreak, we quickly moved to the standard operation procedure of how we should be addressing the outbreak, where we have a robust engagement with the community, the veterinarians, Ministry of Agriculture, Ministry of Health, Ministry of Environment, all the relevant stakeholders. In fact, there was a declaration of a full-fledged outbreak so that the necessary things will be done in order to address this outbreak. All the activities done were done through together with the veterinarians. Then we also have incident action plan, coordination meeting, surveillance, response pillars, outbreaks, everything on daily basis. We are getting an update across human and animal component on how this case has transpired until when we are able to contain it. We also went ahead to quarantine all the animals in that farm and continue to follow them up for 3 consecutive incubation period until when we are free of any doubt that these animals are not part of the affected animals. And all the staffs working in that farm were screened, followed up until when the system is fully assured that they are not in contact with any of these bacteria. So it was a robust activities under One Health. That is how the president was able to contain that outbreak without one single case of human spillover. That is how it has been, and continuously this is what we are doing. And that case gave us a pointer that when has, for those who couldn't understand it, that anthrax case has already gave a pointer as far as the collaboration between the 3 sectors is concerned. And that is how we are working in every aspect of disease. You will see a veterinarian, you will see an environmental scientist, you will see a healthcare component, human part, joining together, discussing together on how they should address issues. That was how we were able to handle that case, and that was how we were able to make it a success story. Thank you very much.
Beautiful. That's great.
Wow.
If I can lend in my voice, Dr. Ibrahim Hassan, it would have been good to have a before and after, to document this and then come and share it at a conference so that other states can learn from it and other countries who can learn from it. And then you can publish it. So, but when you do a lot of good work and then we don't share it, we don't document it. But if you just add all the inputs together, I'm sure this is a very good one. When you talk about antimicrobial resistance, you need to include the farmers and the animals. So it's not just human beings, it goes beyond the health facility. And I think you are really networking and spreading out your wings. And we will get there. So Amaka, over to
The work
you.
was
Over and
published.
out.
It was published. I will share the publication later.
Pardon?
He said it was published and he will share the publication later.
Oh, very good, very good, very good. So Amaka,
Information.
let's
Information
thank you.
is
Thank you.
is still Dr. Abba.
Okay, go ahead, sir.
Anthrax spore is one of the most stubborn bacteria that can exist for so many years in soil.
Yeah.
So there is need for vacation of the incidence points and areas where possible infections must have spread through. There is need for vacation of anything living thing in that area. And sample will be continuously taken over a period of time to be sure that the spore is not existing, because the spore can exist for over 10 years. And if the carcass is not properly disposed, that's another problem. That will continue to harbour the spore, and whenever there is flood, which we are prone to, the grasses will grow, and there is high possibility that if there is grazing around that area, those animals will consume the spore and it will hatch, and the incubation will be completed, and the next thing is an outbreak that will affect both humans and animals. I want to commend Dr. Ibrahim for what they have done, but there is need for a follow-up, because I know this outbreak he's talking about is barely less than 2 years. Because I know there was this information that was shared, there is an outbreak in Zamfara, anthrax, whatever. It's less than 2 years. So there is high chance that the bacteria is still existing in a good form and waiting for the right opportunity to strike. So that area needs to be continuously monitored, and all living things around that area need to be vacated until the area is properly safeguard for a return, and the minimum it takes is 10 years.
That's true. That's true.
Thank you very much, sir. Noted.
Thank you so much. I saw a hand earlier. Mark, do you still want to have the floor? Let me see.
I think we should.
Okay.
Okay, go
Her
ahead.
hand was up.
You said that you're
ready.
ready.
Yes, Ma.
Okay.
Mark, you have a contribution, a comment?
Is it Mrs. Ayorinde?
Yes, Ma. Mrs. Mojisola. Okay. Okay, maybe she's maybe someone has said what she wanted to say earlier. Okay,
Yeah,
so
okay. Let's move.
Okay, so I'll go ahead. Next we're going to unfortunately, Dr. Joanne, our next speaker, is not on the call.
Sorry, good afternoon.
Good afternoon.
That Mrs. Ayorinde.
Good afternoon. Yes, ma. Good afternoon, ma.
Good afternoon.
Good afternoon, ma.
Yeah. Well done, Dr. Ibrahim Hassan. I was just very glad to hear that you are working with MSF, because most of the time when we have NGOs on ground, the healthcare workers, and most especially the leadership, they find it difficult to work with them, thinking maybe they came to spy on them. I just want to say well done for collaborating and your commitment with them. And then try to take some of their soft items, their website, if they allow you, or let them give you their hard copies of their booklet. And in the area of resources for PPE, they used to come to the country with plenty of it. And most often time, if we don't try to collaborate with them, they will take the resources to another facility. So it will be good for you to be able to liaise with their supply chain and the logistic protocol officer so that they can give you enough resources. I'm not saying that your state cannot provide the resources, but I know that MSF, they used to have a lot of resources, both items of soft copy, equipment, and as you liaise with them very well, they will keep on supplying you. Thank you, Anova. Well done.
All right. Thank you so much, Ma. Thank you for that contribution. I'm sure it's quite noted. Someone is asking, will the slides be shared? Of course, you will get this presentation slides to be shared with everyone. I don't know if, okay, so we just have to move ahead quickly. The next speaker is currently not on the call. She has sent in her apology due to network issues. She's unable to join. So I'm going to give the floor to Dr. Bimbola Shawande. Or you can go ahead, please.
Well, let me try and see what I can make of this. The main presentation
I guess it's your network. We're unable to hear you.
I'm muted. I want to make sure. Just a minute.
Okay.
Can you hear me now?
Yes, Ma, we can.
I got disconnected. I think I'm just coming back on. What's that? Can you see my slide?
Is being recorded.
Can you see my slide?
Not yet, Ma.
I think I better do it again. But why is I talking to the slide? The main presentation was meant to have been Dr. Jembi. Unfortunately, she sent in an apology. What I just wanted to do was to give an overview of our ECHO journey since we started. Incidentally, we started April 2021. If I'm right, just a minute, let me try and share my slide. And the need for us to do an audit. We've been brainstorming and maybe you should, I'm trying to see if I can share my slide. Okay, 1 minute. Can you see my slide? Hello?
Yes, ma'am.
Okay.
Yes, we can see it.
Yes, we can see it. Amaka actually did say that 5th of May is around the corner. The basis of infection prevention and control is hand hygiene. And there is a global campaign for healthcare workers on the 5th of May. But I remember 2021, on the 29th of April was the launch. That was when we started. It was meant to, we got a grant for 2 years, 2021 to the end, December 2022. But from there on, from January 2023 to date, NSIC has been sponsoring and keeping it up. Not all the countries that have started are still ongoing because of financial reasons. You have to fund some things, but luckily we're using the small money we made from our conferences to update this. Average